It's a very long way from tea and coffee, isn't it? It's at the other end of the building, but by all means come in. I'll start talking because we're against time, if that's okay. Many thanks for asking me to come back to SMAC. I had an immense time last year. It was a real epiphany for me in terms of medical education. I had an absolutely superb time, and I'm delighted to come back again this year, so thanks very much for that. And in true SMAC form, I had a conversation with Chris Nixon some months ago, and he said, come back to SMAC again, it'll be awesome. It is. And he said, do you want to talk about stuff? And I said, yeah, that'd be great. And he said, I've got a couple of things which I can talk about. I'm quite interested in various resuscitation topics and things. But he went, no. When you come to SMAC, you don't get to come and talk about what you want to talk about. You get to come and talk about what we want you to talk about. And so the title that he's given me today is sort of fairly sort of broad and not particularly specific. It's about do risk factors factor. And so what I'm hoping to do over the next half an hour or so is to talk to you about risk factors and how they affect how we manage our patients in the ED, and in particular how it affects our view of diagnosis. And so there are three major areas I'm going to be talking about. I'm going to be talking about risk and diagnostics, and particularly about you. I'm also going to be talking about how we share our risk and share the values of making a diagnosis with our patients. A little bit about what's called risk proximity, and I'll explain what that is as we go along. And then finally, I'm going to bring that together, hopefully, when we talk about the effect of chronic health disease risk factors in ED diagnosis, because it's not quite as simple as I thought when I first started looking at this. So, on a conference like this, the educationalists amongst you may know this is Bloom's taxonomy, which looks at three major broad areas of clinical learning, or learning and education, actually. And there are three domains which can be broken down into different segments, but I'm interested in these because the psychomotor element, the stuff that Rich Levitan was talking about this morning about intubation, about doing physical skills, about going out to the workshops yesterday and going out to the trade fair, about dealing with new bits of kit. We spend huge amounts of time, don't we, training, doing cricothyroidotomies. How many cricothyroidotomies are you going to do in your lifetime? Now, I'm not diminishing it, it's important, but it's not a big part of our practice, and yet we devote a huge amount of time to it. And similarly, affective domain, which is about our emotions, our relationships, our contributions, our trauma teams. We heard a lot about that this morning, didn't we? We talked about simulation and how people work together. And we're increasingly spending a lot of time in that area as well. And that's good. But the third bit is the bit that I'm particularly interested in, and that's the cognitive domain. And cognitive is not just about knowledge. At the very basic level, it's about what you know. But as you want to go forward as a resuscitationist, as a clinician, you've got to think about how do we do things? How do we think about the way that we think? Because as emergency physicians, I spend far more of my time thinking about stuff and making mistakes in my thinking than I ever will doing thoracotomies. And yet we disproportionately spend our time thinking about procedures. So today, a real focus is to think about thinking, metacognition, and the vehicle we're going to use for that is around risk and diagnosis. And if you've heard me talk before about diagnostics, you'll know that I don't believe that we make diagnoses in the emergency department. What we do is we make probabilities. And we move people to a high probability, in which case we think it's worth treating them or doing something, or we move them to a low probability, in which case we think it's worth leaving them alone. But essentially, we're probabilisticians, not diagnosticians. And that means that we're always managing a degree of risk in our practice around diagnostics, and that makes it a useful thing for us to think about how we handle that data and how we handle those beliefs as ED clinicians. So I'm going to tell you some stories. This is some years ago. This is Officer Smith. Officer Smith is a 36-year-old policeman who presents to the emergency department, and he's a fit and healthy guy, and he's got an episode of chest pain. It's been on and off for about an hour. No particular severe features to it, and it's largely resolved by the time he's seen in the ED by a junior doctor. He's fit and healthy, he's a policeman, he's not hyperlipidemic, he's not got hypertension, he's not diabetic, there's no real history of coronary heart disease in the family, maybe in old age, and he stopped smoking about 5 years ago. And he got an ECG done, which looks like this. I think you'll probably agree this looks normal. Nothing particularly exciting. Now, this is some years ago. If you're in my department now, you only have to move for Rick Body, one of my colleagues, to do a high-sensitivity troponin on you. But this is some years ago, and that didn't happen on this occasion. And he was discharged home, which is fine. Now, I didn't see him on the day. I saw him the next day, and by that time, his ECG had changed considerably. And this was probably As good an example of an ECG that we got out of him on day 2, and he succumbed from his cardiac arrest, and at post-mortem he had a myocardial infarction. Now, this is obviously a very bad thing, and lots of people asked questions, and there was an investigation. And many things came out of that, but one of the things that stuck with me at the time was one of the explanations for why that had happened, and one of the justifications and the explanations and the understanding in our support to colleagues was that he didn't have any risk factors, so he probably wasn't a high-risk patient, so we didn't really do anything about it. Contrast that with a gentleman, and I'm sure you'll see many of these in your departments. This is also Officer Smith. He's a 72-year-old retired police officer. And he turns up to the emergency department with a 2.5-minute history of central chest pain. But he's a bit more interesting. He had an MI about 5 years ago, which was treated with PCI. He's an ex-smoker of 5 years. He's on statins for hyperlipidemia, and he's on well-controlled hypertension. Clearly a high-risk patient. So unsurprisingly, he had an ECG, which the clever amongst you will realize is exactly the same as the other one, because I was struggling to find one. And then Brazil nicked my other ECGs for her presentation this morning. Total chaos. But there you go. He has this done, and we admit him for a rule-out myocardial infarction screen. I think it was roughly about the 5th time we'd done it this year, because he's a bit of an anxious chap, and it wasn't positive, which is unsurprising. And he's a very happy bloke, and we let him go home. And it was questioned, and we wondered why this was done. And it was basically, we went down this path because he had risk factors. He felt risky. And so we decided to do something about it. And I think that's interesting, because if you go through those cases, can you feel and can you understand why those things were done? Does that feel relevant to you? Does it feel relevant that when you see a patient who's presented to you in the emergency department with chest pain, do you automatically ask about risk factors? Do you automatically ask about hyperlipidemia, hypertension, smoking, coronary heart disease? You do. And I do. But that's interesting. We're going to come back to that. So we've got a bit of agreement, I think. So the first thing I wanted to talk about was who's at risk. Who's at risk in this scenario? Who's at risk of an adverse event? And clearly, the patient is. There's absolutely no doubt the patient holds the risk of ischemic heart disease and something bad may happen. But I put it to you. I put it to you that we hold part of this risk as well, because any adverse outcomes, which can happen, are going to come back and people are going to look at our management of the patient. And in that second case that we talked about, the reason to admit that guy for rule-out myocardial infarction was because he had risk factors, and because if something had gone wrong, it would have been unreasonable to send him home, and there's more of a feeling that you get pinged for it. So our behaviours about what we do with patients are affected by the presence or absence of chronic disease risk factors. It's what we do. This is coronary heart disease. I can give you many other examples. And similar to that is this concept of risk proximity, which affects our behaviour as clinicians. So risk proximity is in risk management, and it's about how proximal and close you feel a risk happening. And I suspect that this chap or a lady probably feels a degree of risk. It will probably create some sort of visceral feeling of tachycardia, tachypnea, sweating in a wetsuit, dilated pupils, etc. And that's a clear and present danger to this person. And it feels real, and it's likely to change their behaviours. But in contrast, you've got things like global warming. And global warming is much more likely to cause us problems and kill us than shark attacks. Arguably not necessarily here, but certainly back home, that would be the case. But we don't feel it. It's far away from us. It's not a proximal thing, and it doesn't change our behaviour. And we see that people don't change their behaviour about climate change, even though it's terrible. But they would about the shark. So is there any correlation with that in medicine? Well, I think there is. I work in a paediatric trauma centre part of my time, and I can tell you that we're very fearful of missing injury. We're extremely fearful of missing occult injuries in our major trauma patients, and we're very, very fearful of missing things like subdural hematomas and non-accidental injury. And that's driven us, that fear, that risk proximity of missing something which will come back and bite us in 2 or 3 days, is driving our practice to increasingly CT our children. And yet there's good data, isn't there? There was a nice paper from Australia published in the BMJ that showed that the increase in CT scanning is inevitably causing us a rise in cancers. But we don't feel that. That risk is not proximal, it's much in the distance, and we will never find it, we will never experience it, we will never feel it, and we'll never get pinged for it. So that doesn't affect our behaviour. So how risky it is to us as an individual will influence our behaviour about what we do. but we're emergency physicians, and in particular, the emphasis is on us being emergency physicians. And so we do naturally have a focus around what's happening today, what's happening this week, what's going to happen to my patients in the next few weeks. If you're in an environment like the UK where we have pretty good primary care services, you can let patients disappear off back into community and hope that they get picked up then with issues. I do appreciate that other people around the world feel that their primary care services are very poor, so they have to manage everything in-house, and that does affect your decision-making. But for me, I'm in emergency medicine. I'm mostly focused around what's going to happen. And so that brings us back to where we started thinking about those two cases, about risk factors, and whether risk factors for disease actually influence us as emergency physicians. I think they do. I think they influence our behavior, but should they? So a number of years ago, we were doing a study. It was a diagnostic cohort study looking at patients who turned up with chest pain compatible with myocardial disease. And we followed them through. It was a diagnostic cohort study, and we followed them through and decided whether they had an MI or not based on troponins. It's a fairly standard thing. But what Rick did, and Rick's at the conference, it feels like a concert. Rick's at the conference. What Rick did is he went back and he had a look at the data, and he looked to see if the presence or absence of chronic health disease risk factors made a difference. Because you'd expect that they would. You ask about your juniors, you value it, and in those two examples, I think our behaviors demonstrate that we take notice of it. But it was really interesting. We looked at things that we know from things like the Framingham longitudinal studies make a difference to the presence or absence of ischemic heart disease. But what we found was that there was very little difference. Now, difficult to read, I will show you the nice graph. This is the graph that shows you the accumulation of risk factors and the likelihood of you getting myocardial infarction, or you having had a myocardial infarction. And this doesn't make sense to me. This should rise, shouldn't it? The more we have, the more likely you are to have an MI. But no. And if you like rock curves, and I love rock curves, everybody else should, if you wanted an example of a rock curve, which is the epitome of the most useless test in the history of diagnostics, this is it. I've never seen a rock curve before or since which is so ridiculously pants as this. It should be up here, but it's absolutely rubbish. There is no association with it. But was this Manchester? Is it just because we've got weirdos in Manchester? No. Jays looked back in 1992 and showed that the classic coronary risk factors make no difference, and that was in about just under 6,000 patients in the US. And an even bigger study by Han, looking at about 17,500 patients coming through the ED, again showed no association with chronic heart disease risk factors and the diagnosis of MI in the ED. You can look at prognostic scores, the TIMI score. Well, they're there. This is prognosis after you've made the diagnosis of ACS, but you need to get 3 to get 1 point. Doesn't seem to be a particularly strong association. And similarly with the GRACE score, looking at 6-month mortality makes no difference. And in other conditions, such as pulmonary embolus, it's only really a previous diagnosis of PE or DVT which make a difference. Things like thrombophilias don't feature in these scores. So why is that? Because it doesn't make sense to me when you look at this data, and it was a bit of a surprise. So we had to go back and think why it is that our model of disease is wrong. It doesn't seem to be making sense to us. And because I think this is the way that we're taught. I think this is the way we experience medical school education and the pathological process. And our medical model of disease is that risk factors take place. You have an underlying condition, and that leads to disease, and then leads to diagnosis, and then leads to outcome. So things like hyperlipidemia, if you're hyperlipidemic, you'll get lipid deposition and form plaques. The plaques will eventually rupture, you get a coronary heart disease, and that's what happens. But the reality is it's not the case at all. It just doesn't work like that. Because for the vast majority of patients, they may have a risk factor, but in fact, disease may never occur. Most smokers don't get lung cancer. Most people with hyperlipidemia don't get coronary heart disease. And so that linear model of association is just not valid. And we're more interested, because we're acute physicians, in what the acute events are that have brought the patient here today. And so graphically, you've got people with disease. Some of the people with disease will have risk factors, but many people with disease won't have them at all. And in fact, most people will actually experience, who have risk factors for whatever condition you're looking for, won't actually feature in the population of disease that you see in the ED. These things are just carrying on in the community. There are many people in the audience today who have numerous risk factors for loads of different diseases which they'll never manifest in terms of pathology. So that's interesting. So that's one reason why it might not be. But what else? The other is we have an over-exaggerated view of the importance of underlying risk factors. This was a nice paper that was put out only this year, really. We've got a big interest in thromboembolism, and we have a lot of patients in Manchester who we think have got underlying thrombophilia. And so I've asked colleagues, when we've talked about this before, how likely do you think it is that somebody who's got one of the major thrombophilias, like protein S deficiency, would develop a DVT or a PE over their lifetime? And you can have a little thought in your head already, but most people, in my experience, certainly in Manchester, would go for somewhere about 50% or more. Because we have that medical model in our head that these things are really important. But actually, the data's really not there. If we look at protein S deficiency here, this is events per 100-person years. So even something which is really a strong risk factor doesn't actually feature in these diseases. So our medical model of disease and the importance of risk factors is probably wrong. The other thing which I think may really influence the population that we're seeing in REDs is the chicken and egg situation. So what comes first, your risk factor or your diagnosis? Well, pathologically, it's clearly the risk factor. But in terms of knowledge of the patient and understanding, it's not necessarily the case at all. Because diagnosis, if you come in with your acute coronary syndrome, is at the point when we might actually notice that you're diabetic, that you're hyperlipidemic, that you're hypertensive. And so you only develop your risk factors and you only identify them once you've reached the point of diagnosis through the first occasion. But that still doesn't explain it, because then you'd still expect more people to come back and have the diagnosis later on. I've put this up because it's mentioned by some people, but I don't believe it. There is quite a lot of rat studies out there that show that if you're hyperglycemic, so one of our risk factors for coronary heart disease being diabetes, is you lower your pain thresholds. It's never been repeated in humans, but I thought I'd put it up there just as a passing thing, just in case you come across it. The other thing is thresholds. When do patients come to the ED? And we're strongly influential in this as clinicians and as health services. If you go to NHS Direct, which is the UK sort of filtering system, do you come to the emergency department, you go to your GP or anything like that, you can ask them, and you can log on, you can probably do it from here, in fact, and you can ask them about whether or not you have chest pain. And I did this the other day. I just logged on and said I've got chest pain. I had no associated features. I wasn't sweaty. I wasn't short of breath. It didn't radiate to my arm or to my neck. I was absolutely fine in every way apart from the fact that I did say that I had chest pain, until I came to this question, which asked me if I'm currently being treated for any heart conditions. And unsurprisingly, it just tells me to come. And we see similar data in the data that we put to patients when they leave hospital after their initial event, after their first time that they've had a diagnosis. And same sort of thing. This is a quote from the health angina leaflet that's used in the UK. And it tells you this: if the pattern of your pain changes, go to hospital, essentially. But it's not very objective. It's a judgment call. And all of these things, what they do is they effectively lower the threshold for people who've had a diagnosis to come back to the ED, and therefore dilutes the effectiveness and the importance of those chronic risk factors in your diagnostic process. And we even have this up in billboards around the hospital. So we're never short of business. So where does that bring us to? I think the evidence is there. The evidence is clearly there that what we think about in terms of our history taking and the value that we attribute to chronic health disease risk factors in our patients, particularly in things like coronary heart disease, just isn't valid. It just is counterintuitive, and it risks us making mistakes. It risks us making the mistakes that we talked about in the first two patients of either underdiagnosing and ignoring things because of their absence, it has no relevance, or over-investigating, over-treating, using scarce resources for people who have risk factors but nothing else to suggest that there's something going on, which is just purely wasteful. So dilution, our perception of what's going on, whether we're actually making our risk factors appear through diagnosis, and lowering our threshold for patients to attend in the ED with chest pain if they've had previous episodes. So where does it leave us? I suppose the question is for you. What are you going to say when next week one of your juniors comes up to you and say, I've got a 36-year-old guy with chest pain that was sort of central here, doesn't really do anything, he felt a bit unwell at the time, but he's fit and well, he's a policeman, and he's got no risk factors. Are you going to value that as a judgment, or are you going to ignore it? And similarly with the other guy, if somebody comes and said they've got 2 minutes of chest pain, which is a bit like their angina, but they were running for the bus, but it's gone now, and they're absolutely fine with a normal ECG, would you investigate them still? And same in other conditions, would you value your likelihood and probability and frequency of chronic disease risk factors for other things like DVT and PE? So in answer to the question, which is where we started really, it comes back to you. And the original question that Chris gave us was, do risk factors factor? And the answer is yes, they do. But they only factor for you and you as a clinician. They don't seem to factor that much for your patients. And therefore, when you're thinking about your thinking, when you're thinking about your performance as an emergency physician, you need to take this into consideration and make sure that you're taking note of important information and not getting fooled. So final thoughts, final slide is really this. Goes back to where we started at the beginning. This is a fantastic conference. You'll spend a lot of time doing psychomotor stuff. I'm sure if you were at the workshops yesterday, you learned to do airway, all sorts of video laryngoscopy and things. You'll do lots of effective stuff, you'll do lots of social learning, and that will be brilliant. But I want you to spend a little bit more time thinking about what you do every single day, every single patient that you see, and think about your own thinking and thinking how sometimes you get a little bit muddled up because the data isn't there to support it. Thank you very much.